Kristen to recap briefly what happened for those who are joining us, and we'll then go on. Is that all right?
Yeah.
Yeah, I think that would be nice.
That's what we'll be doing. Okay, we've got. Is anyone more left to join us? I just said that.
Judy is there?
Yeah,
she's
Judy is there. Okay.
Yeah,
Annabelle is not there. Annabelle?
Oh, yes, Annabelle is, yeah, I knew there's someone not there.
Annabelle.
Annabelle, I think is not joining us. There was an email. Isn't that right, Dr. Russell?
No,
no.
That is Vivian.
Vivian.
Vivian, that's right. Okay.
Just recap. One of my, I just spoke to Kristen. We have been, Derek, have a look at if Annabelle comes in, so we'll let her.
Yeah.
One of the things that we've been doing on the platform of the UNESCO chair, pharmacy, dental, and family therapy, and so forth. One of the things, this becomes a great opportunity for all of you. We brought together from virtually the world. Most regions of the world are here. So we don't have a continued or extended conversation after this, looking at possibly one of you will leading and having some guidelines, and so with come across from all of you together. And there'll be also the opportunity to have the proceedings of these webinars to be published as with all of you as authors, and in the Global Bioethical Inquiry, which is an index journal of the UNESCO International Journal. I asked Kristen, who is now on the board, to coordinate that. It will be a joint paper with all of you, if that's all right with all of you. Okay? And we'll discuss, and we'll put this together after this is over, all right? And we'll have, we'll probably speak and look at what you all want to do after that. We might extend, and all of you on the panel will be, so we'll have a continuation of the discussion and so forth.
Annabelle is there. One
okay, Derek, I think Sharon from Hong Kong. Just see if she's there today.
She was to be there. She said she would be.
Yeah, Annabelle is joining.
And we have, it's Des Cahill. Professor Cahill is...
Annabelle, hi, welcome.
Hello, good evening.
Good evening.
Good evening. Where's Annabelle? Where's Annabelle? I can see. Oh, hello, Annabelle.
Hi, Annabelle.
Hello.
So there's only Sharon, I think, who should...
Sharon, you have to search for Sharon.
Yeah, I'm just doing that.
Okay, we'll
Derek,
Yes.
just keep an eye on Mr. Samuel Ravi Kumar. I want to bring him in for a discussion.
Okay.
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 He's from CMC Vellore, Mr. Samuel Ravi Kumar.
Ravi Kumar, okay.
Mary, remember the lady Gallagher, Anne Gallagher. She wrote back again. Yeah. Do any of you know Anne Gallagher? Does anyone know Professor Anne Gallagher? She's
the editor of Nursing Ethics, I believe.
Yeah. No, that's what she's got. Which university? Yeah, she's the editor-in-chief of that. And that's Des Cahill is here, who writes Professor Des Cahill. Welcome, Des. So we have, who Des will give it to you. He does the executive summary of the program, all the various, which is put up on a web alongside with the recordings of the webinar. Okay.
Okay, I think we can admit everyone, Dr. Russell, since it is 5.
Yeah, sure. Go ahead.
So.
You didn't find Sharon?
Yeah,
no, not yet. But if she comes in, then it's easier to find her once she's in the meeting.
Okay.
So I'm putting the YouTube link as well. So if any one of you want to forward that on WhatsApp or any of the social media to your other groups, you can do that as well, and people can watch the recording there.
You opened it up, isn't it, Derek? So,
Yes. We have about 125.
Okay.
Now, Dr. Geeta Lakshmi is also
Dr.
there.
Rizal Ribelli is there. We have invited her, no, from Miami. Ribelli Christie is here.
Yeah, I think she joined today.
She joined
Rebelli, you
today.
can you unmute yourself, please?
I never got a response from her. So
We
Yeah,
got a
I
response,
did now.
Dr. Annie. That's why we didn't know whether she was there.
Yeah,
yeah,
Ribelli Christie,
she
answer. They are
replied to my
calling you.
letter.
Oh, okay. I can hear you.
Yeah, please go ahead. We can hear you.
Okay. Can you hear me now?
Yes, we can.
Okay.
Introduce yourself, Christie.
My name is Rebelli Christie. I work as a nurse practitioner here in Florida for the past 7 years. Before that, I was a bedside critical care nurse in Florida as well. And right now, I'm practicing with an internal medicine group. I graduated from Florida International University. I did my master's at CMC Vellore, and I passed out in 2004.
All right, welcome, Steve.
Thank you.
Welcome. Okay, let's. So I'll welcome to all distinguished panel from around the world, and also to all the participants for the second or the session 2 of the webinar with the title Nurses, Bioethics, and the Response to the COVID-19 Pandemic. So today we continue with that program, the conversation that was started and went, we had a very good session. It was outstanding. Areas were covered. We had all of the panelists there, and Professor Mary Matthew, the moderator with Professor Derek D'Souza, took us through that the 120 odd minutes or more, and now we've come to the second session, which is going to look at other areas, including education and public health and areas that were not covered there. For all of you who might have not been there, or some of you that might not have been there for the first session, I will quickly just reintroduce our panel today. We have Dr. Annie Grace Calamati, who's the convener. She's also the head of the National Nursing Bioethics Program of the UNESCO Chair in Bioethics in India. And we have the co-chair, it's Dr. Kristen Jones Bonifiglio from Canada, Lakehead University. And you know, Kristen, and when I introduce you, if you put your hand up or shake it, wave out, people will know who you are. And Kristen is the head of the unit, a bioethics unit of the UNESCO Chair, one of the 250 centers we have, or around 250, in 58 countries across all the continents. So, so Kristen is a co-convener. And then we have Dr. Salva Titus Chaco, who is the Dean. Welcome, Dr. Salva. She's the Dean of the College of Nursing from the Gulf Medical University in the UAE. And we were delighted to hear what wonderful work is being done at her university and in that country. We then have Dr. Catherine Digani Condon from New York. She is a nurse practitioner from the Division of Palliative Medicine and Bioethics at the Winthrop, New York. I think it's a cancer or palliative center. Is that right? And I'm delighted also now to bring to introduce to you Annabelle Brown. She's my colleague from Australia and indeed from Melbourne, Victoria. She's a clinical nurse facilitator at Holmes Glen. And then I go on to Miss Raya from Israel. Now, she is a healthcare stimulation specialist and in the emergency room. She's a nurse in the emergency room at the Sonoka University Medical Center in Ben Shiva in Israel. So welcome to you. And then we have Dr. Judy Arulapan, who is a professor at the College of Nursing at Muscat, at the university in Muscat. And then I'm delighted that we have Karen Cassilis, who is from Canada, from Woodstock. And Karen had some difficulties last time, but we welcome you today to join us. Although I know you were listening to the whole program last time. And Karen is an enhanced psychogeriatric resource consultant at the geriatric outreach team in Woodstock Hospital in London, Ontario. And I'm delighted also that we have Miriam Waguru from the director of the School of Nursing from the Nairobi University in Nairobi in Kenya. And finally, we have Dr. Joyce Newman, who's the program director and the advanced practice registered nurse and the adjunct ethicist in the section of the integrated ethics. And this is at the Anderson Center in Houston, Texas. And we go on to introduce to you today Miss Joy Kejila, who is the chief of nursing at the Fortis Muller Hospital in Chennai. Welcome to you, Joy. We also would be should be having with us Dr. Sharon Leong, who is the head of nursing education at the Hong Kong Baptist University in Hong Kong. So I think with that I've covered all this.
Rebelli Christie.
Oh, yes, sorry, because you're not there. Yes, Rebelli Christie is a nurse practitioner at in Miami in Florida. Is that right? And now with internal medicine. So welcome, Rebelli, to the program. And we also had Dr. Geeta Lakshmi, who's the Vice Chancellor, but she was particularly involved in establishing the nursing bioethics program in India, the national program with Annie Grace. Okay, so Dr. Mary, you might like to welcome everyone before we, and Derek will give the house rules before we then. I'm going to ask Kristen, our co-convener, will give a recap, a brief recap, so that we take off from there. Is that all right?
Yeah, that should be okay. Yeah, thank you, Dr. Russell, and good morning, good evening, good afternoon to all of you. Welcome again. This is part 2 of our webinar series on nurses, bioethics, and the pandemic COVID-19. And lovely to see all of you back again. And we do have the same strength. We're having a very, the participant strength also is quite good. So Hopefully this time we'll be able to bring in some participants, answer some questions. As always, to all those who are participating, please put your questions on the chat box and we will try to address them. And Dr. Derek, would you like to give the house rules, please?
Derek?
Is he there?
I don't know. He's
okay. So so if you have any questions, please put it on the chat box.
You want to give your house rules?
Yeah, thank you, Dr. Mary. Welcome to all the participants. Good to have you back in such large numbers. And of course, our wonderful panel who are here full strength. So it's really good to have each one of you. Just in order to maintain the quality of the telecast, we request all the panelists, other than the panelists, that is all the participants, to kindly keep your microphones muted as well as your videos off during this meeting so that we can get better quality, as well as you can see the panelists on your screen at all times without any disturbance. In case you have any questions or comments or queries, kindly put them in the chat box. The other panelists are also monitoring that and they will answer you directly, or we will collate all the questions towards the end and put it up to the panelists, and I'm sure they will answer your queries as well. So you'll get your doubts clarified and you can follow the telecast as well. The meeting is also being simultaneously telecast on YouTube Live. I've put the link and I'll be doing it again just now. So your students or the faculty or friends can also watch the meeting there directly. Even if they haven't had time to register, they can just click on that link and they'll be directed to this meeting as well. Dr. Russell, if you could just start your recording as well, and then we can go ahead. Thank you.
Right.
And I'll also be putting some documents and other material that has been very kindly shared by our expert panelists. So all the participants can visit those links or download the documents, and I'm sure it will broaden the knowledge of each and every one of us. So thank you to all the participants for being here once again, and over to you, Dr. Russell.
Right, I just wanted to, before I hand it to Dr. Christine, I just wanted to say that we usually do this at the end. We try to bring in a couple of participants with questions or comments to bring them on the screen so that you could place that. So please put your questions into your chat box, and Professor Derek will be monitoring that and will inform you and ask you to be if you have to come on the screen. Okay, so I'm going to, without much ado, I'm going to hand you to Kristen, Dr. Kristen, who's going to recap and set the scene so we go on today. Thank you
so much, Dr. Russell. So special thanks to Dr. Russell and his wonderful team, so Dr. Derek, Dr. Mary, and Dr. Annie Graves, for organizing this important discussion both last week and for today. I bring greetings from Lakehead University Centre for Healthcare Ethics here in Thunder Bay, Ontario, Canada. So last week, if you were able to join us, we discussed a number of topics. I feel like really the discussion was just getting started, so I'm so happy to continue it here today. We discussed solidarity as a moral value. We discussed the ethics of commitment, opportunities for beneficence versus fear, the stigma of COVID, policy and decision-making, challenges with testing, really across different countries, across the globe. We talked about shortages of PPE and what that means for nurses and whether or not nurses what they should do about that and whether or not they should be working under those conditions. We talked about the use of untested medical therapies, so issues of consent, informed consent. We talked about nurses' mental health and well-being, so resilience, the use of telemedicine, nurse staffing shortages, and also the numbers of deaths of nurses and other healthcare workers due to COVID. So presently here in Canada, so with a country with a population of almost 38 million, we have almost 120,000 confirmed cases, and that's an increase of about 3,000 cases since last Sunday. Globally, cases stand at over 19 million confirmed cases, with over 700,000 deaths, with almost 12 million recovered from COVID. Today, we welcome panelists from Australia, India, United Arab Emirates, the USA, Israel, Oman, Canada, Kenya, and Hong Kong to continue this very important discussion among nurses. So thank you to everyone in our online audience. And I think without further ado, I would ask to turn this over to Dr. Mary, our very skilled moderator, to get the discussion started today. Thank you.
Thank you, Kristen. And
Thank you, Kristen.
Thank you for that, for the overview. So for those who didn't participate, were not there last week, I think you missed a lot. But anyway, we have the recording and it's being sent. So you can listen to what all we have discussed. But I'd like to take this forward. Now, Dr. Miriam had mentioned in one of her, we were asking about what should we discuss, about the role of nurses in policy making. And how much of their voice is heard when it comes to policy and guidelines. So what I'd like to do now is, I will start with Dr. Annie, and we want to know, Dr. Annie, do we have, do nurses have a voice in policy making in this COVID-19 pandemic? And is it, you can speak for Tamil Nadu or even across India, if there's any policy in place?
Good evening and good morning to everyone. And I'm really glad for that question, what Miriam has asked. Actually, if you ask in India in general, I would say at the policy making table, still we are yet to catch there. Though we have at the council, at the directorate level, there are a lot of posts are really vacant, which is not being taken over by the nurses. It is from other professionals who are holding the post, but whereas we are not in the table. If you take a government hospital, the nursing superintendent, even if you just think of an example of in India, she is not in a policy making like procuring PPE. She is the one, the nurses, who they are going to wear and everything, and which one is best and how much it is needed, or even to planning the resource material. It is not really taking place in our country, basically. And in Tamil Nadu, certainly I could say in India, I'm really sure, because in most of the committees I do been involved, and the policy level, we have to really catch up, and we are still voicing out that our voice to be heard. And we need to really working through the associations and through the representations from the associations, that our voice to be heard. And for example, now our association, National Association, they have given a lot of representations even now for the COVID deaths, that nurses also should be included in the insurance policy. When there is a death, there is a nurse is dying, then she should be included in that policy of the 50 lakhs which government is offering. Even that one was initially not there. Then after associations have given voice out, then it has been included. So it is like that. So maybe if a nurse would have been there in that policy table, she would have been really thought about her. This is what I always think about it. So I think in India, we are yet to, and I think there are times are coming up. This COVID has given a visibility that how important nurses are, and people do recognize, and I wish in future that will happen. Thank you.
Yeah, Dr. Annie, the reason is because can the nursing council represent, nurses, what is going on about the nurses regarding the pandemic? Can there be a representative from the council to the government level for,
Of course, it would have been nice, Dr. Mary, as you say, but most of the time we are not invited in those teams.
But is it required that you be invited, or is it?
Yeah, in the government level, it need to be until there is an invitation, I can't be going and attending the meeting. Okay, I need to have an invitation, otherwise I can't be.
But is there, okay, right now we are in a situation where, nurses are not invited. Is there a way we can circumvent this problem, or at least,
Yeah.
start the process where nurses can be involved in government decisions regarding pandemics?
That's what I said now, no, that actually in initial insurance policy, the doctors and alone been included first when it came in the draft for the, if any death happens in the healthcare providers, nurses been not involved. After that, they have given a representation through association. It's a national association. That is Nurses Association of India, where they have given a representation. Then after that, they included. But every time we do give a send a letter that some of the things they have started including us recently. Even in the Clinical Establishment Act in Tamil Nadu, they have put Nursing Council Registrar as one of the member. So it is taking place, but it is in a very slow manner. But I hope this pandemic has given a visibility. So they will be definitely including the nurse members in the policy making. For example, last week, my health minister has called me and asked me, Annie, what is happening? We are not able to open up the colleges and schools. Why not you say, think about your final year students to come over to the field? And we were planning something and how other states are done with that. For example, Gujarat have utilized the final year students only for the screening of COVID patients, and they were paid a honorarium of 9,000 rupees and under the supervision of a nurse, because they have not yet registered themselves and obtained
Yes.
the license. So something is happening, and so I thought it's the best recognition. So far, they never called us like that for a discussion. So a week back, he called me and he said, we need to. So I have given a proposal to the secretariat how it need to be done, how it need to be meticulously planned. How the first year, second year, and third year students to be utilized, and the final year students. So, but still, we are in the process only. It has not been finalized.
Okay, that's good, because it's a start somewhere, and that's a very good start. But my request to you is, do not let it go, because the pandemic is an opportunity. But after the pandemic, it should be that voices of nurses should be heard even after the pandemic. So it's very important. So I think it should be continued. Thank you, Dr. Annie. Can I go to Kristen before I go to the other panelists? Kristen, do nurses have a voice in policy making in Canada? Is there a voice, especially with regard to this pandemic?
Yeah, so certainly through associations like the Canadian Nurses Association and provincial nursing bodies, but I think it's quite varied. And I would also say that there's a very strong presence of physicians, probably globally, making a number of these decisions.
Yeah, but nurses are represented.
I would say that it's probably varied across the country how that would occur. But we do try to have a strong voice through our associations.
Thank you. Miriam, you raised this question about government policies from Kenya, Dr. Miriam.
Yes. Good evening, good morning, good afternoon, everyone. And thank you, Professor Rizal and the team and Professor Mary for having me here. I raised that question because although we struggle through associations, I think it would be important to have definite structures.
Okay.
You look at the Ministry of Health and you have the directorates within there. There are about 6 directorates. Nursing, according to the law, should be one of the directorates, but nursing has not been given a directorate yet. It's now called not even a unit. So I think that in as much as the associations and the unions and others are thinking that we need to have our voice made, but we think that there should be an inbuilt structure within the ministry so that we have like the Department of Nursing as one of the departmental heads. So when the departmental heads are making a decision, they don't need to be invited. If it is directors making a decision, then the nurse is one of the directors. Then I also feel that apart from having 6 directorates headed by medical doctors, we could have other, like the pharmacists and other healthcare professionals, because the healthcare issues are unique. and every person, every healthcare professional needs to be invited. So I was looking at this opportunity and the space you have given us, and I was thinking that we can form a team from here. We have a few nurses, form a team, and with the help of UNESCO, we work towards ensuring that there is justice in governance in Ministry of Health globally.
Okay, because this is a platform where we can all unite together. We have representation from different countries. So that's really a good idea. Dr. Miriam, thank you. I'll come back to you because we have to take, I want to take from Australia. Annabelle is there. Annabelle, are you there?
Yeah, Annabelle's there.
Yes, I am, Dr. Mary.
Annabelle, is there, are nurses represented in policy making when it comes to pandemics in Australia?
We have the Australian and Nursing Midwifery Council here, and someone from there represents, but it's not fully represented to the full extent. They do look after, the federal government does look after GPs, but they don't really hear the voice of the nurses as much.
But why is it not happening?
I think they're not open to it at the minute.
But how do we go forward in this? Because
we have to go through the Australian Nursing and Midwifery Council. Someone there has to push the issue towards the federal government and state government and get someone in there to actually voice the opinions of the nurses who are at the bedside.
Yeah, because we are talking about doctors and doctors dying and doctors getting infected, but nobody is talking about nurses getting infected, nurses dying. Nobody has numbers and statistics. So I think
we do have numbers, but it's not nursing in general. It's the healthcare workers.
Okay.
But nurses in Australia, in Australia, the ANF, your nursing council. Now we've got APRA, which the same council.
That's the registration council.
Yeah, the registration council, who is now in this country. Doctors, nurses, physicians, visit all are under the same council for registration and for governance. It's also governance.
But are they represented there in terms of taking forward their needs?
No, from that governance, yes, they are. But there is the ANF, and I think compared to many countries, Australia, the nursing definitely have a better representation, but may not be as Annabelle has said. But I think there is. But I've seen the nursing, what they're having issue. In fact, right now there's a whole program that they were showing about one of the nurses who's been affected, infected or having become positive and gone through. There's a whole issue thing about on TV itself. So I think there is that, but might not be having as much as in the federal. What you're saying is the from the Commonwealth where you have the GP, where they have that program, but in the state, each state, but this is a federation, so the states control one portion, and the Commonwealth does the other. So so that's.
No, my question is any of the nursing association in any country, are they tracking how many nurses have fallen ill, or are they how many have died to the disease? Is that happening? Let me ask. Annabelle.
Joyce put her hand up.
Yeah, I'll ask Dr. Joyce. Annabelle.
No, as I said, we don't have a tracking for nurses as a separate entity. It's the whole healthcare workers.
Yeah, but that's not. I don't think that's correct. I mean, I think we should know how many, because they more than doctors, they are also in the front line, and so it is very important that we know, because I think Dr. Miriam has written there, when a doctor dies, the president talks about it, but when the nurse dies, no one talks about it, and which is so true. And I think that's very unfortunate. I think we should, at least at those who are in the administrative level, look into this and see why nurses are not represented. Their representation is not enough. I think it's very important. Thank you, Annabelle. I'll just ask Dr. Joyce. Dr. Joyce from USA.
Hello. Yes. Hi.
Yes.
Can you hear me?
Yeah, Dr. Joyce. How is
So,
it in the USA?
so actually, I looked at my professional organization, the American Nurses Association list and website after our call last week, because I wanted to correct my my number, and I did find in the American Nurses Association 241 nurses have lost their lives due to COVID.
Okay, so there is someone is tracking it, so that is very good.
Yes, it's not official though. I mean, it's through our professional organization. So in that sense, it's official, but you know, it's not something, I can't say the news media has focused on healthcare providers, but I think physicians, you know, have a higher say in terms of that. But
but how, Dr. Joyce, how do we improve this? We have to do something. I mean, we can't just let it go. Now that we have a platform, we have a voice, I think we should take it forward. How do we improve this?
You're absolutely right. We need to improve the sense in the media and in our society of the role that nurses play. I think you know, there's been a lot on Facebook and other social media sites here in the States with you know, talking about healthcare providers and heroes and what heroes nurses and doctors. So I'm seeing some increase in the realization that how important nurses play, what important role they play. So I think through our professional organizations, through nurses running for office in our politically and getting involved politically is very important, and making sure we touch base with or contact our representatives so they're aware of the important part that we play in our voice so we can advocate for nurses.
Yeah, that's true. Because if you're not in touch with the representatives, how are they supposed to know?
Right.
I just saw what Kristen has just put up, that the International Council of Nurses is tracking.
Okay.
And she's put this up, and there are 600 nurses so far that have lost their life. 600 nurses have died around the world with COVID. So there seems to be an organization called the International Council of Nurses.
Yeah, so I think we should make sure that all countries are represented there, because I don't know if this is the actual.
Only 139 countries representing the ICN, 139 countries alone.
Okay, and is India in that?
Yeah, India is in it. Yeah.
And
it's probably
but
like
I don't think
WNA.
from India we have given any statistic.
It doesn't look like it, because it looks very low.
It's very low. Yeah.
Yeah. Right. Okay. What about Dr. Selva from UAE? Dr. Selva?
Yes, thank you, Dr. Mary. And once again, I want to thank everyone for this opportunity. It's wonderful to see everybody. But as Dr. Mariam had very clearly said, the structure of healthcare is absolutely important in terms of any country, and the representation in that structure for nursing is what makes the significance. So in UAE, we have the nursing directorate. So the person on top, and she has her whole team of people who actually in this pandemic, if I might say, from what I spoke last week, they were fully involved in terms of deciding what would be the ratio of people who look after the COVID patients, what kind of, which hospital will be COVID, which is not COVID, how would the nurses, where would they stay, how would they function, which students, as you said, we were talking about whether fourth years would come in, and all that decision was made from the nursing directorate so that the manpower can be substituted. And also, as I said, that practicing nurses, those who are not licensed in the country, can be brought back, and how the training can be given. So I would say in this country, the structure of this healthcare structure, which has a very good place for the nursing director, had a lot of implications in caring for the pandemic patients.
So do you have a record of nurses who are infected?
I am not too sure about that. I'm afraid I cannot comment. I cannot comment. I can only say from what I understand, the way it functioned actually. But I probably can find out, but I'm not too very sure. But I know for sure that the healthcare of the nurses were taken care very well, because whether they get infected, whether they're insured or not, all of them given free treatment. Absolutely. Because I told you that one of them was on ventilator, the whole family was admitted, all of them were written off through whether they were insured or not. So that kind of care was provided to them as well. But if you ask me whether records of their, whether deaths and thus, I'm sure it is, but I could not comment directly about it. But I would say that being a small country, they have got a very good placement of the nursing directorate in the health directorate.
Yeah. Right. Thank you. Dr. Judy in Muscat.
Good evening, everyone. Thank you for the opportunity. Good evening, everyone. Thank you for the opportunity. So in Oman, we have Director General who is representing Ministry of Health institutions. And he is the one who represents the whole nursing fraternity of Oman. And we have Oman Nurses Association as well. And as Dr. Selva Titus rightly mentioned, we too have COVID hospitals where this Director General who is involved in allocating nurses from other hospitals who will be able to take care of COVID patients. They are shifted from, say, for example, some government hospitals, some nurses are shifted to another hospital where COVID patients are taken care of. So such arrangements are done by the Director General in Nursing, who is in the Ministry of Health. So therefore, the nurses in Oman are really protected, and they are safeguarded in terms of their health as well as security. And as such, we do not have any tracking system for the nurses who are falling sick. However, on the whole, for the healthcare workers, we have a tracking system. How many are infected, how many are seriously ill, and how many are recovering. We have such data in Oman.
Yes. Okay, right. Thank you, Dr. Judy, because I think it is important that we address this issue. Thank you so much, all of you, for this was an important point Dr. Miriam raised, and I thought it is relevant that it's high time nurses get represented. And I say this even to my physician colleagues. The reason why we are not represented, even as a doctor, is because we don't take part in politics. And it is very important to have a voice as a healthcare worker, to have a voice in the government setting. And that is why we should be represented not only in terms of, in the political sphere, but also in the legal sphere. So I think it's very important that doctors, nurses, all healthcare workers be aware that, they have to be involved in policy-making decisions, when it comes to their profession. So I think this portion was really good. And I think we've learned from some countries. It's very easy in a small country, like Dr. Selva said, but we are talking about USA, India, where it is just, too big to even think about such things, but it is not impossible. We have to make a start.
Dr. Mary, can I just put one input here? Yeah. Actually, in the recent National Health Policy 2017, Government of India sent a communication to every state government to establish a directorate of nursing. So it is the state responsibility now to establish. Only in India, West Bengal is the only state which has a directorate of nursing. None other state are having, but there is a proposal based on the 2017 policy. But as everybody said, associations need to fight, and we need to represent and make it happen soon.
Yeah, right. And this is the right opportunity also to do that. Yeah, thank you so much. I want to move on to another aspect that we are talking about, training of nurses and education of nurses. Now, this thing crossed my mind. Are nurses being trained? Is it part of their curriculum to train for pandemic, to be ready in terms of pandemic? Is it part of the curriculum? Can I have Dr. Joyce I'll come back to, I know Joy and all are there. We'll all come back. Dr. Joyce, in USA, is it part of the curriculum that nurses are trained to be ready for any pandemic? Dr. Joyce Newman?
Yes. Yes. I'm sorry. I was unmuting myself. The nurses do get some training in critical care in that. I personally am not involved in nursing education right now, although I have been in the past, but I know right now the schools of nursing are doing more online things, and it's unfortunate in terms of some of their clinical. They are in their critical care course. Most of the most programs, I believe, would have some information and some education on dealing with this situation that we're dealing with now.
No, because it's very important, because we are going to see a series of pandemics, and we are seeing it, and it's high, and it is not there even in the medical curriculum. So I was just wondering, is it there in the nursing curriculum, where nurses are taught how to deal with a pandemic? So in USA, you're saying it's not really given that much of importance. It may not be there in the curriculum.
You only had it once in a lifetime. In 100 years, that's what. So I think.
No, but when I say pandemic, I don't mean just COVID-19. I'm saying in terms of everything, disaster, and you know.
Yeah. So there is.
Dr. Mary, can I comment?
Yeah.
Can I comment, Dr. Mary?
Yeah. Yes.
Yeah. If you look at Indian Nursing Council's curriculum, as well as if you look at even UAE curriculum, it has something on disaster nursing. Okay, which is, you know, it could extend from war to any kind of disaster, including how to handle when there is a mass casualty, with regards to how you address a problem that is.
How many credit hours?
Yeah. Okay. I would say that it actually started as Dr. Annie is there. It started as a course, actually, if you might look at. We have emergency medicine, into which it started as a parallel course. If you say especially credit, I don't know exactly how we can say a few, about 30 hours.
No, madam, it is only disaster management. It is only 15 hours in a curriculum.
15 hours. Okay.
15 hours.
So
That
which year do nurses get trained in disaster management?
In the second year.
Second year.
Second year.
In second year.
In second
Can
year.
I give,
and
can
also,
I
I want to tell you, in Tamil Nadu, it is a mandate. Before any graduate passes out, she should have attended the disaster workshop. It is a mandate from the university. And also, I would like to give one information. Actually, I am involved with one UK-based group. About 10 countries, we have taken the curriculum of 10 countries. Still, we are under process. So I'm not telling this, which are all countries are involved. We are looking at whether any pandemic word is there, whether pandemic preparedness in the curriculum is there. Actually, when we looked up, we had almost, I think we are crossing the 4th month now looking at the curriculum. Everybody say it is only disaster. There is a word pandemic as mentioned, but not pandemic preparation as such. Nothing is there in 10 countries syllabus.
Dr. Annie, is it enough to prepare the nurses for the pandemic?
No, it is not. It is not.
No.
It is not enough. It is not enough.
That
is why we are looking at the curriculum, whether we need to include this, how to recommend. That is what the research we are doing. 10 experts from 10 countries, we have joined together and we are doing that research. Actually.
I think it is important. It should be in the curriculum now, because
a combination of infection control is there. When you talk about general infection control is also there, which is not, as Dr. Annie said, it's not coming as a whole curriculum as such, but infection control is one of the biggest aspect that is taught in a second year student, when they go in medical nursing, because they work with isolation patients who need to be isolated, how to take care of them. So how to protect oneself and how to protect the others. So that is there. But as a pandemic preparedness, we cannot, clearly say, and it has this many credits, but then people are developing. That is exactly.
So do you think we should recommend it?
Dr.
No, I think what we could do.
Just put a hand up. Dr. from Israel.
Yes,
yeah,
Dr.
I want to say that first of all, definitely we have in the curriculum the infection control. It's a mandatory piece in the school, in the nursing studies. Lately, because the pandemic was just came suddenly, no one was expecting that. So definitely the students got resources. And we know that there is a huge resources online from all over the world. And many of the resources are free without any cost, which is make it more available for students. The same thing in Israel. And another thing is that I want to say that we have a unique program, a master program, which is called Emergency Medicine and handling the disaster events, which include also pandemic. And this is a master degree, which open to nurses. Any nurse that is interested.
Raya, I'm saying, is it there in the undergraduate curriculum? Because master's is a different thing.
Yeah, so in the undergraduate curriculum, we have a program that it's a combination of registered nurse and paramedics. This program includes also handling and managing crisis, which also a pandemic crisis. It can be different. It can be like aircraft. It can be any kind of other disaster. But any kind of disaster.
Okay, so Raya, are you telling me it's sufficient for the nursing students? Is it okay? I mean, is it enough, or should it be more?
Do
you think more should be added?
Tell you if it's enough, I don't know. It's something that must be evaluated, because again, it's the crisis, the humanity crisis that we're going through right now is something that was not expected, and definitely the size and the global consideration of this crisis is something that I don't think that any program actually considers something like that. So saying that, I can say that we do cover infection control. We do cover in some of the programs handling and managing disasters. And we have the unique program of, as I said, disaster management and emergency care and medicine. And this is open for nurses. I can say one thing, that we have a very advanced emergency service in any crisis, not just pandemic. We got a WHO award for opening a quick, like a field hospital, the most advanced hospital that can be arranged in like 24 hours. This was got appreciation from the WHO. So we have the tools, we have the knowledge how to handle. Nurses are part of it. Nurses taking definitely a key status. I won't say they're the only one. We also have physicians, all the disciplines that are taking definitely a huge part of it, but also the nurses are getting those nurses are getting a special training to be part of those teams. We send not only for this crisis, but for many crises across the global, we send our teams, and they were new, like very expert and very trained.
Yeah, because Israel, Dr. Miriam, I'm coming to you. Because Israel is quite ready for anything. So I think that's why I think they have a lot of systems in place and policies in place. Dr. Miriam, you were saying something.
Yes, thank you for giving me the opportunity. I want to agree with my colleague from Israel. I was in Rabin Medical Center for some time. I was taking emergency and trauma care there, and I appreciate the kind of preparedness they have. But coming back to most of the hospitals, like where I am in Kenya, many nursing schools teach about infection prevention and control. They also have some little disaster management, and there's also disaster management as a postgraduate course. But I do feel that the curriculum of the basic nursing training does not have how to care for the people in pandemics, because pandemics is more than the physical aspect. It also includes how you communicate, includes how you take care of the psychosocial aspects of the people who are involved and their families and the ones who are working. So I was feeling this because we may not be able to put it in a curriculum, but we may have a clinical or a fellowship course where every year we are talking about disaster or pandemics, and then we run it, and from time to time we call in the qualified staff to come and take the course so that every time we are always ready for any emerging pandemic. I know that like in Israel, when I was there, from time to time, their hospital workers go to, the males go to sometime in the army, so that it takes, they are ready all the time. I think we should do that every year. We have a situation where nurses are taught maybe 3 weeks course in pandemics all the time, because pandemics keep coming and they come differently and they have very different implications. So we can have every year we can have a course maybe 3 weeks, where every year we have nurses being trained, and these nurses are posted and they can be trained, they can be trainers of other nurses where they are. Thank you.
Yeah, that's very good, because once they're trained, it's important that they go back and they teach whichever organization they are in. And UNESCO does that. We train teachers in bioethics, and we tell them, go back to your universities and train your other staff in bioethics. So I think nursing, in terms of pandemic and education, that also should happen. I want to know from Canada, Karen is there. Karen, we have not brought you in as yet. Karen? Is Karen there?
Yeah, she's there.
Yeah, please unmute yourself, Karen.
I'm working
please
on
unmute
this.
yourself, Karen.
Hi.
Yeah.
Hello, everyone. Very, very informative conversation. Building on what has been discussed by panel members so far, it's very important to have organizational responsibility when there are new hires. Certainly, most graduate nurses are graduating at a younger age and beginning into their profession at young ages and not had significant amount of exposures. So in a hire following graduation, it's important as well to have that knowledge and to build on that education piece. It's part of what we do currently within our individual hospital here. We have the annual education renewal, and it is a piece of that practice training, is to be certain that people are competent in that aspect. Our infection control definitely governs what are the public health guidelines and follow the appropriate college standards.
Yeah, but Karen, tell me, is Canada, is it included in the curriculum?
There's my understanding in the epidemiology course that's taught in the university or the post-RN program. I know for sure with the epidemiology course, they do cover pandemic preparedness, but it's an overview. It's not really the brass tacks of what a day looks like when you work through the pandemic. So in terms of the learning, I think there's certainly some on-the-job learning that comes from working in the current situation.
Okay, all right, Karen, thank you, because I'll bring in Kristen, because Kristen probably, Kristen?
Yes, thank you, Dr. Mary. So certainly across Canada, the curriculum varies depending on the different provinces and different institutions. We do have community health nursing, we have pandemic preparedness, disaster management, infection control, absolutely. But I think that this pandemic is going to definitely impact curriculums of the future in terms of giving new graduates what they need. And included in that, I would say there also needs to be a really robust piece around mental health and well-being within the pandemic, not just the hands-on skills, but as was mentioned previously, I think by Dr. Miriam, how do we meet the psychosocial needs of our patients and our colleagues and ourselves as well?
Yeah, so I think there needs to be a modification now in what we term as, it's not just infection control. When we say pandemic, it's not just infection control, there's something more, and there are many aspects to this. And instead of it being a specialization or a master's program, if it can be, part of the training as an undergraduate nurse, at least some aspects of it, I think that's very important, that, that will be a a good way to start.
Yeah, Dr. Russell. In Australia, not at, I don't know about the undergraduate, but there is the Australasian College of Health Service Management, which is open to nurses, doctors, managers. That there is disaster, and of course, for in the Royal College of Medical Administrators, and at a more management level, they all have pandemic in the whole area of disaster management, pandemic and epidemic management comes in that realm. So I know nurses. I'm a fellow of that college, and many nurses are fellows of the Australian College.
But can I get Annabelle in? And can I get Annabelle in and ask what about the nursing curriculum in Australia?
Annabelle will know. She's teaching.
Yeah, thank you, Dr. Mary. In answer to your question, you're asking whether it's part of the undergraduate curriculum. And I can honestly say no, in the diploma and the undergraduate level, no, it's not part of the curriculum. We do have, like the others said, infectious control, but it's not preparing them for a pandemic as such. But after this, maybe it'll be up for discussion and inclusion into the curriculum.
Yeah, so I think, and there are different aspects to this pandemic. It's not just dealing with the immediate, what is the emergency part of it, but much more, even the fallout of a pandemic, I think that should be included. Yeah, Raya, you wanted to say something? I'm coming to Joy and Kathleen. Raya, you wanted to say something before I go to Joy? Is Raya there?
Raya is here.
Yes,
Okay,
Raya, you can go ahead now. Yeah. No, just a minute. I think you're muted. Yeah. Okay, go ahead now, please. Yes.
Yeah, I just noticed lately, in addition to all the thoughts about how the curriculum should look like, I think that the importance of public health studies increased lately. I think that we always had all kind of public health programs, but I think that the voice of the public health programs currently becomes stronger because people from all the disciplines realize the importance of being knowledgeable about public health. And we saw a shortness of, especially in the epidemiological investigations that we have across the country, that there's a shortness of expert people that are having the knowledge and the experience in public health, how to protect the public in situations like that. So I definitely agree with Christine, which I think that that's gonna impact the future studies and the future curriculums. And maybe, hopefully, there'll be more resources and more thoughts about how the public health studies will be integrated, not only in the undergrads curriculum, but maybe in some other programs.
Okay, thank you, Raya. Joy is there? Joy?
Right, good evening, good morning.
Is Joy Kezia there?
Yes, I'm here.
Hi, Joy, your opinion on this, including this into the curriculum, and your experience, how much have, while doing a nursing, have you come across, were you prepared for a pandemic?
Right, my answer would be 50-50. The theory about pandemic or the theory about emerging and re-emerging diseases, theory about communicable spread, theory, knowledge about H1N1 and SARS and stuff like that. Yes, theory-wise, we've had very good exposure in our community health curriculum, public health curriculum. The theory is very good. But on the flip side, I would say like how we prepare simulation. Like, we even do simulation for code blues. We do simulation for code yellow, which is mass casualty. we do simulation for trauma management, but I must accept that we never do simulation for a pandemic, because we ourselves have never been part of being a frontline pandemic worker until 2020. So, you know, going forward, I think me being part of being an administrator and being a nurse at the core, I would strongly recommend that we do get this into, you know, a really simulation-based training, a standardized training tool which could be offered to our students at the level that's appropriate, as you know, as a council would decide at whichever age the student nurses would be able to embrace themselves to fight such pandemic. I think the way forward must definitely be this. And also at this point, Dr. Mary, talking about the policies that you were discussing in part one, you know, I strongly feel that different administrations, different hospitals do keep their nurses and nursing leaders part of their policy making. And I am really proud and happy to say that many hospitals do keep nurses part of their decision making. And at this point, I would like to, you know, cite 4-letter E's. First is we do need to equip our nurses, and it's not about me just desiring to be part of a policy making group, but then I need to equip myself as well. You know, if the decision is going to be about business review, me as a nursing head, don't you think I should equip myself? You know, I do need to learn about it. I need to empower myself about it. That's the second E. The third E that I talk about is I want to say that we need to constantly engage with nursing leaders, constantly engage with students, constantly engage with frontline workers, so that the potentials, that the potentials and the capacity, the capability of every single nurse is brought to the table. And final E is we expand as a community, we expand for policy making, we expand during a pandemic. You know, we positively expand in telling that we are ready to handle whatever that's, you know, whatever whatever be the disaster that's thrown across to us. So it's not just you know, the desire on one side that, you know, I'm not being part of a policy and we are not being respected or we are not being called, but I also see at the other side, am I really equipped to be part of that policy decision? Have I really empowered myself to be part of such a decision? You know, I think nurses must go out of their comfort zone or out of their, you know, their nursing skill, and venture into finance, venture into pharma, venture into different other departments to make our voice heard. You know, we are strong alone, but we can be more powerful if we work with other team members as well. So I think that these are the few takeaways that I would.
Yeah, because interprofessional education and interprofessional working patterns are the way to go forward.
Right.
Because we cannot work in silos, and that's practically impossible. And that's what we are seeing right now. Certain groups are taking decisions, another group is taking a decision, but it's not really. You know, and as someone has said, Nirmala Ravi has said, entrepreneurs are the need of the hour. So true. I totally agree. Thank you, Joy. That was beautiful. You had your 4 E's all ready for us. Okay. So can I go to Kathleen?
Dr. Mary Rebelli is raising her hands.
Yeah, I'm coming to Rebelli. Let me just finish, Kathleen. Rebelli, I'm coming back to you. Is Kathleen there? Kathleen from USA?
Good morning.
Yes,
from New York. And
yeah, Kathleen, I'm sorry. This is the disadvantage of having a very big panel, a huge panel that some people get to be last and second last.
So, you know, here in the United States, Eileen Larson out of Columbia University, who's a nurse, did seminal work on infection control. That has been critical here in the pandemic. But, you know, I think the time that we have within the curriculum here in the United States for nursing, there are so many areas that fail to get the attention needed. I work in palliative care. It's been, you know, very hard to integrate that into the curriculum, although it's more present now. So I think it's oftentimes curriculum catches up in response. I don't think there has been a lot built in around pandemics or disaster training.
Were you taught during your training?
No, I think during annual trainings within hospitals, there is some disaster preparedness, but it's not built into the curriculum. And so I think curriculum sort of catches up. There has been ongoing, education in response, but I don't think the United States as a country has had to deal with
a pandemic.
With a pandemic, I think we've had some natural disasters, but it has not been a part of the fabric of the United States.
So, do you think the simulation exercises which Joy has been talking about would help?
I do think so.
Yeah, because that's a very good idea. I think that's a marvelous idea that she's put forward. To have this thing about simulation exercises for pandemics.
And just to that point, to determine what's involved in that really needs the voices of nurses, because what physicians are encountering maybe are certainly different than what the bedside nurses. There's some overlap there, but it is different. And I do think, I think we need to give nurses credit for the knowledge that they bring to the table.
Yes,
there's often a reference of doctors.
Yes.
In truth, there are many doctors sitting on this panel here today.
Okay.
And so I think it's important to identify that nurses bring, many nurses bring that terminal advanced knowledge in their profession. And
the thing is, Kathleen, I don't disagree with you, but what is the nursing fraternity doing about this? Because yes, they are very important. Everyone knows that, but are they making steps to make it known? Because if everyone keeps quiet, nothing is going to come out.
So I do think, in the US, the Deputy Surgeon General was a nurse. And was the acting Surgeon General during this administration. That has since changed. But in the White House task force, there is no nursing representation.
This is the problem, because we don't see the voice of nurses. Unless they're represented, how will people get to know what is happening? So I think that, this discussion itself is very important, because we have to find ways, the UNESCO is a platform where we bring people together, where we find a place for nurse voices also to be heard in this pandemic. And I think it's about time that all of you start thinking about it.
Agreed.
Yeah, right. Thank you very much. Rebeli, you're there. I hope you're still there.
Yeah, I'm here. Can you hear me?
Yeah, Rebeli, you were not there the previous session, so that's how, tell us your experience. Did you were you trained for a pandemic, and do you think it is important to introduce it into the curriculum?
Yeah, I graduated in 2012 here as a nurse practitioner, and I don't remember being prepared in the curriculum for a pandemic. But we did have.
You're in USA, right?
Yeah.
You're in USA, Florida, right?
Yes, I am. But we do, as mentioned by the other people earlier, we do get trained on disaster management, especially in Florida, we get hurricane every year. So the hospitals and the curriculum, we do get trained on disaster management. And even the hospitals, we have teams for the hurricane season. Like, we have a pre-hurricane team and a post-hurricane team. So we do really get trained well enough to manage a disaster, but never for a pandemic. If you ask me, when you are students rotating in the hospital, we do get trained for infection control, like personal protective equipment use in a proper way. We do get trained for that. Like, students or anybody getting like recruited as a new registered nurse in the hospital, they do get trained for proper use of PPE. But now I was renewing my license last month. I do see, like, we do have to do some credit hours every 2 years to get the license renewed. And now I see COVID-19 is being included in the part of the CE. So that way, and not only that, the hospital is also providing continuing education. Usually we have to pay for it, and now they're doing it for free. So they're doing something to immerse the knowledge of COVID-19 to the nurses and the students as well.
All right. Thank you, Rebeli. Thank you very much. I'm going to, kind of end this this part of the session on this thing. What is it? Voices of nurses and their role in policy making. I just want three of our senior faculty to give their final opinion or their thoughts on this. That is, I want Kristen, Annie Grace, and Joyce Newman to tell us how we can take this forward now. Annie Grace, I can start with you, Dr. Annie.
Yeah, sure. Certainly what we, as we discussed today, like it is a mandate that we need to integrate pandemic into the curriculum. And as Joyce said, now it is simulation-based training everywhere. Actually, our Indian Nursing Council has made a syllabus review. I hope 2021 they are going to introduce a new syllabus. I wished and I hope they would have taken this one as a part to include pandemic as one of the things with the simulation-based training. Because now, if you see the medical curriculum, also competency-based simulation training is that have been made as mandate. The same way nursing curriculum also been made. So it is a one thing we need to welcome all that. And as Christy said, the continuing nursing education, the CE, she said, and already our government of India introduced IGOT training there. Lot of training being given at free of cost for our nurses throughout the country. And we have encouraged from our council, all the nurses to take up, and we are giving a credit hour for them to renew their license. So these are all the steps we have taken on the whole as nurses of India. Thank you.
One moment, Annie.
Yes,
all right.
What about,
thank you, Dr. Annie.
What about, you're talking about the curriculum. We have Dr. Geeta, who is the Vice Chancellor. For the nursing curriculum, the university does puts the curriculum together. Is that right, Dr. Geeta?
No, sir. It is the Indian Nursing Council. They are the authority to make the syllabus and the curriculum.
So doesn't the university?
No, university, if they want, they can give additional training onto it, but cannot,
exactly. Nursing Council only should do the curriculum and syllabus. No other person cannot touch on the curriculum or the syllabus. Only the Nursing Council can.
Like how Medical Council, the same way. Isn't it, ma'am? Am I correct, ma'am?
Yeah, exactly. But Medical Council, at least the guidance would be there and we can modify it slightly. But Nursing Council, you cannot do anything on it.
Madam, I don't think it is not so. The new 2021 syllabus, it is coming up, and they have given a little lenience stating you can add anything about, but you have to maintain the full standard. That syllabus, it's a standard.
Minimum standard.
The minimum standard, and little bit you can add according to your, for example, Tamil Nadu. We face in Chennai all the time cyclone and flood. So you can add a little bit onto it. So like that, they are giving a lenience in the new syllabus.
Okay. Yeah. So, Dr. Annie, I'm hoping that pandemic will be included in the curriculum. That means.
Yes, I'm hoping so. I too.
Yeah. Thank you, Dr.
Talking about how you take this to the policy, that's a different level. When you take it to the government, where you become part of the policy. This is syllabus.
The syllabus, actually, they have made a draft syllabus. They have put
I know that.
Public opinion.
I'm talking about going to policy where you are on the panel. Make what Dr. Mary was asking. That's a different. One is the curriculum. The other is how you get into how you are represented at the level of policy making. Is that right?
Yeah. Both are different. Yeah.
So because that's the next thing you got to see, how do you get, you have here, I just saw your president of the Physicians of India is on the, he's up here, Dr. Arulraj. Did you see him? Ask him how the physicians got on the panel, and tell him that Dr. Arulraj, the president of the Physicians of India is on. I saw him there. He's one of our colleagues in the UNESCO program. Yes. Okay.
Can I go to Dr.
Yeah.
Kristen? Dr. Kristen? Kristen?
Unmute yourself.
Thank you, Dr. Mary. So one of the points that I wanted to make, and I see that it's running in the chat column here, is that really the need for the practical pieces for nurses. So it's fine if we provide theory, but how do we get that into action so that nurses can, do the best that they can on the ground? And so I wanted to acknowledge something that Kathleen had mentioned, and that's preparation for really good quality palliative end-of-life care, and making sure that nurses know how to participate in and facilitate goals of care and advanced care planning conversations. I think in terms of practical skills, that's something that's probably always been in every nursing program, but how can we make that more robust, more to the forefront, maybe an entire course on that instead of just threading it through, the last lecture in a critical care course, that type of a thing. So I think there's a lot of room for palliative care to really shine in terms of the need for it and the way that nurses can really use one of their strengths in terms of making a positive contribution in a pandemic.
Yeah, what about the curriculum, Christina? What I was talking about, do you feel there's a need to change and to add on and introduce it either as a certification or as, because I'm not too confident. I mean, I don't like the idea of using it as a master's program.
Yeah, I would agree with you. I think it needs to be an undergraduate. Certainly there's room for it in master's programs, continuing education and continuing professional development. Also from an interprofessional perspective, I think it's important for us to work outside of our professional silos so we can make sure that we're working with other people.
Yeah.
And again,
Yes.
I'm always working from a strengths-based perspective. So what does nursing bring to the table to contribute to that, the larger effort of the interprofessional team?
Yeah, all right. Thank you, Kristen. Dr. Joyce, your opinion?
Hello, can you hear me?
Go ahead. You can go ahead.
Okay, thank you. As my fellow American nurses mentioned, I think I totally agree with them in terms of the need for program development is there. I too, know that the American Association of Colleges of Nurses, I would imagine, are going to speak to some of this, because as was mentioned in the US, we have not had a disaster such as this, although we're familiar in Texas too with hurricanes and what can happen. But you're right, is we need to include this in the curriculum in some form or fashion. There is continuing education through our American Nurses Association. Hospitals are also having simulation disasters, preparedness and things like that. But that's again when the nurses get to their employment, wherever that might be. So there's a lot of variation throughout the US related to this topic. I think as was mentioned before, getting involved.
Do you, Joyce?
Yes.
Joyce, do you think we should have simulation exercise for pandemics?
I think that's a very good suggestion. I know in the hospital when we do disaster training, as our employer sets up, that there is some, related to that. I know there's radiation preparedness in case there's ever event that would cause that radiation to be an issue. So, but again, you know, I think at least some curriculum that would include this, and also, you know, we need to, as nurses, get more powerful, whether that's, you know, politically or through our organizations, institutions, or UNESCO. I mean, this has been a great forum for combining interest and looking at the future.
Yeah, right. Thank you, Dr. Joyce. So I think we have discussed about, you know, how it can be either introduced into the curriculum, or in some way nurses are prepared for a pandemic now. I'll just move on to the last bit of what we want to discuss today is the physical, mental, and spiritual well-being of nurses. How important it is, especially during the pandemic, and what are we doing about it? Because the trauma that psychological, physical, and there's probably I'll say even spiritual trauma, because this is a time when people who believe in God start questioning whether there is a God. So are we equipped to, are we ready for, dealing with this? Because it's a holistic view that we have to take when we take care of our own fraternity, people from our own fraternity. So I'll start, let me start. Dr. Annie Grace and Dr. Christian, I will come to you at the end. Okay, so let me just take voices from our younger colleagues so that let's hear what they have to say. So I'll start with Rebelli, because Rebelli was not involved in the previous one. Rebelli, you're there? Dr. Russell, you want to say something?
Yeah, I just add to what you said, moral distress and moral injury. That's been a big thing that from the medical workforce, we are seeing moral distress and moral, when you can't do what you want to, what you had planned or what you are called to do, but because some of issues beyond your care, your ability, moral distress. And nurses do have, I know that it's moral
helplessness,
distress. So think about that.
Okay. Rebelli, Dr.
Yeah.
Rebelli.
So I do more clinical, and in the hospitals where I practice, we do have hotlines. Like, you know, if you're burned out or you wanted to get some support, we do have hotlines where you can call them. And I haven't done it, so I don't know what the process is, but you do have support, and we do have.
But
like,
is it open? Rebelli,
Yes.
One moment. Is it open during this COVID-19 pandemic?
Is it available? They actually opened it for the pandemic. We do have some support lines before, but now it's like very active, and you can talk to them, and there are psychologists and psychiatrists available online. You can go for counseling. They offer counseling in the hospitals where we practice. And if you're completely burned out, you can even take a week off. But we do.
What about spiritual counseling?
Spiritual counseling.
Do you have a system in place for spiritual counseling?
Yes, we do. Yeah,
pastoral
we do have
counseling or whatever.
Yeah, we do have chaplains in all the hospitals. And now, after this pandemic, we do have services 2 times a day, in the morning as well as in the afternoon. And some days, most of the nurses who are free, they come in front of the hospital, and we do have a prayer together. And yeah, the chaplains are always available now. And if you need any counseling, you can go to them in the hospital.
Okay, what about the physical physical aspect of it? I mean, if they are sick, or how is it taken care of in Florida if a nurse falls sick?
Okay, if the nurse falls sick from COVID-19, then you stay home for 2 weeks, and you need to be tested negative twice before you come back to the hospital to practice. It's applicable for everybody. It's not just for the nurses, for the doctors, or anybody in the hospital. You get sick from COVID-19, you stay home, and then after 2 weeks, you need to be tested twice negative to come back to the.
Okay, what about insurance and compensations?
Insurance wise, I know some of the insurance, they did, like, you mean asking for the spiritual related thing or?
No, insurance, if they fall sick physically, and does insurance cover or does the hospital cover?
As far I know, some of the insurances cover them, and I'm not sure with all the insurances. I know in Florida, Humana is one insurance. If you get hospitalized for COVID-19, you are not charged.
Okay, right. Thank you, Rebeli. Joy? Is Joy there? Joy Kezia? I love that name, Kezia. So unique.
Unmute yourself, Joy.
Joy, yeah.
Yes, I'm here.
Joy, your physical, mental, and spiritual well-being. You're the head in Apollo there. So.
Sorry, Fortis.
Fortis.
Yeah, Fortis. I thought it was Apollo Fortis. Okay, Fortis. Yeah.
Right, Dr. Mary. Yes, many times I keep saying this, and I'm saying this again here at this forum too. When COVID-19 patients are admitted with us, all of us here understand that the family members of the patients do not visit them.
Okay.
So actually, holistic care is provided by my nurse. There is no patient attendant or the family member. So the nurse becomes a counselor to the patient, number one. Leaving aside all of the struggles that the nurse herself faces, she puts up a very brave face. She takes care of the patient head to foot. She serves diet. She's the physiotherapist. She's the nurse. She's sometimes the doctor. She is also the family member to the patient. But like we just spoke of the moral distress that the nurses do go through, the pandemic as such is really not a big part of their distress. The distress is that they cannot connect with their families. And that is the big distress that I have seen in my, few months of experience with them. They are quite confident once they've learned how to don themselves and how to protect themselves. And, very beautifully they've been working. But end of the day, or end of 7 days or 8 days, that little feeling is there that they would love to see their parents, that they would love to talk to them. It's not about this, video call. It's about touch and feel, a hug, the warmth of your own home. So, the lockdown has become a huge stress on nurses, I would say. And, girls and boys want to go to their homes for very silly reasons, fearing that, we would not really send them out somewhere if they give us, just an ordinary reason as I want to go home to see my mother. The administration might say, why do you risk yourself? You're working in a COVID-19 area, so why do you want to take infection back to your home? So, you stay with us, you can go a little later. So this sort of a scenario, what we've tried to do is to talk to the families along with the nurses and ensure that their child is kept safe, that their child is nourished well, sleeping well, they are not overworking, they are provided with, the right amount of PPE, and they're guarded. They're really, really guarded. And if they get sick, the hospital completely takes care of them free of cost, and they're back to their feet. So this is the maximum support that we've been trying to lend them. And, nutrition, time to time, their menu has been changed, trying to make food more, palatable for the nurses who fall sick. Sometimes they're unable to eat, they don't feel taste, they're unable to smell. So we try and, serve the best that we can and make sure that the nurses are really comfortable. We have small groups and small mentors, and we do have a few video games coming up for them. We do have competitions. We recently had a selfie competition, nurses trying to post something good about themselves or the little challenges they face. And yes, we do understand that all of us are stuck, away from our homes, although I do come to my home. And of course, yeah, even my parents are part of the city, but yes, we've not been able to visit them. So, it's
Yeah, Joy, the thing is, to me, you look so young, but you address your staff as boys and girls. And that is really, I mean, I can understand that you feel for them. So I think you're the mother there for them. But it's nice to know that you have that they have a support system, because I understand many cannot go back home for at least 14 days. They are working, right?
They haven't gone home for past 3-4 months. Only this
4
month
months, yeah.
the lockdown has kind of become a bit lenient, and they are able to obtain their e-passes. We do allow them. We tell them please go and come back safe. So, and most of them who've gone have come back. It's not like they want to leave us or they don't want to come back and work. So
That's very good, because that they want to come back, because that shows that the environment they work in is very healthy and thank you, supportive. Annabelle, where is Annabelle there? Annabelle, Australia?
Yeah, she's here.
Thank you, Dr. Mary. I think in Australia there is quite a lot of support.
Annabelle, do you address your students as boys and girls?
Yeah.
You said? Oh, okay.
Here they give, I think we have a lot of support given to the nurses here, mentally and physically. We have counseling. As I said previously, we have the employee assistant program that is free of cost for all nurses and employees, and for all health workers. They can also have the mental health. The government has put in a lot into the mental health, and there's free counseling given that the nurses can access. They have free testing. If they want to get tested, they can go and get tested. They don't have to be showing symptoms.
Okay.
They can go and get tested at any time if they want to have that peace of mind that they are not positive.
Yes,
or
because that itself is stressful.
Yeah. So they can get tested. Then again, if they are positive, the government will pay, or if they come in contact, the government will pay the 2 weeks, whatever leave they want to take to go into isolation.
Okay.
Also, some organizations now say if the nurses don't have place to isolate, that they're scared their roommate or their family member, they might bring the infection back to them. They are putting them up in other alternate accommodation, say in a hotel or somewhere, which is free of cost. So there's no cost to them at all. They, at the discretion of the unit managers, if they're really exhausted, they can actually ask for a few days off. In mental health, a lot of the nurses are now doing telehealth, so they don't have to come in contact much with the patient, saying that they're still tired, but there is support given there. If they're not comfortable looking after a patient, they can refuse, especially in community care. If they don't want to visit someone and they're not comfortable, they can say no. It's not forced upon them. Coming to the spiritual care, yes, there is pastoral care, but it's up to the person if they want to
avail it. Fair enough.
Yeah.
All right. Thank you. Thank you, Annabelle. Thank you so much.
Thank you.
All right. Judy, Dr. Judy.
Okay. So, as I already mentioned, though the nurses are fully supported by the government economically, psychologically, and spiritually, I happen to speak to some 12 to 15 nurses who are really caring for COVID-19 patients. I really had some interest in speaking to them so that I will get a realistic output from them. So when I spoke to them, a few of the nurses expressed they really feel like going to their home country. They are just waiting for the flights, because they don't want to stay in this country, because they feel they are so isolated, and the people are not visiting their houses. The people are discriminating them. Since they are working in ICU, people think that they may contract the illness from the nurses. Therefore, people are not visiting, and the children are isolated, and the neighbors are not even opening the doors. And the nurses felt so bad. They mentioned that really we wanted to get rid of this place, and we wanted to go out of this country because we wanted to land up in our own country. That is what the psychologically some nurses are very frustrated, though the country is very supportive, but the nurses personally are supportive, very much frustrated because of the society and the system. And some nurses express that they should have at least 12 hours duty instead of going for 3 to 4 shifts weekly. If they are given 12 hours duty for 2 days in a week, so that the minimal exposure to the hospital will be there. So they wanted to have less number of days going to the hospital, having 12 hours duty per day. That was one of the issue they expressed, and they said if they are giving some countries are providing something called as gold card. That means the nurses can stay in those countries for a long time. So, however, in these countries, we cannot stay for a long, like in the sense once in a year or once in 2 years, our contracts are renewed. Therefore, some nurses expressed that the nurses who are really caring for COVID patients, if they are given some gold card system, so that we will have this job assurity. So that was one of the feelings they expressed. And as I mentioned, the special pay, the risk allowance is provided for the nurses. The government is fully supportive of the nurses.
Yeah,
Apart from that,
but there's a difference working in your country and working in some other country, and your family is elsewhere. Yeah,
exactly. Otherwise, the counseling services are available, the spiritual support is provided, the psychological support is provided, we have pastoral care as well, and all these are taken care of. However, these are the personal feelings of the nurses.
Truly understandable. It's truly understandable. Yes. Thank you. Thank you, Judy. Kathleen? Is Dr. Kathleen there?
So actually my own doctoral research is in moral distress. And so I think this pandemic has raised much of that issue where the crux of moral distress being nurses feel impeded to do what they perceive to be the right thing. And, you know, I think there's been a considerable amount of moral distress in terms of care futility or what's perceived as care futility, but that's also juxtaposed with an illness and a disease trajectory that's unfolding right in front of us, which has been challenging. I think the isolation that patients have experienced has been considerably troubling to nurses. In my own research, I looked at the role that palliative care could play on mediating the intensity and frequency of moral distress, as well as workplace empowerment. And giving nurses an opportunity to voice their concerns played a really considerable role in reducing the frequency of moral distress in nurses. So we had nurses use a screening, a palliative screening that we've used in our ICUs traditionally by residents, training physicians, and essentially just move that tool into nurses' hands. And what we found was that having nurses bring the results to the attending physician or the physician fellow who really had a capacity to move the conversation within the ICU resulted in a significantly reduced frequency of moral distress and a significant increase in workplace empowerment. So nurses perceived after this study that their workplace was empowering as an institution and that they felt empowered within the institution. So, you know, I think this ties into our earlier conversation around where are nurses here in COVID at the highest levels of government. I think giving nurses an integral voice, and I think, yes, organizations and national organizations are very important, but if they're not interweaved into the political and institutional structure that's really able to make changes, I think they remain a voice, but not a voice that, I don't know, the seriousness and the power that's accorded to that voice is really then left at the hands of the institution or the government to decide how important that voice is. Unless you're in the conversation, I think it's difficult.
Okay, no, the thing is, Kathleen, what about what people are talking about is also about the spiritual and the aspect and the physical aspects. Is there enough support for the nurses when it comes to physical, mental, and spiritual support, especially now.
I do think so. I know within the workplaces that I've been involved in, you know, there's generally employee assistance, but even at critical points within the hospital, whether it's where nurses or other staff punch in on computer screensavers, there's been lots of information about additional resources in the time of COVID. Okay. But I think I was trying to get to the point of Dr. D'Souza had made earlier about moral distress and how do we address moral distress. And so I don't know how well articulated that has been within COVID. I think we're just working sort of in that Maslow's hierarchy of needs. We got to just many times just meet those immediate needs, but thinking more broadly, I think we've had to draw on other experiences and have had to apply it here and in the face of COVID.
Thank you so much. Karen is there? Karen from Canada. Thank you, Kathleen.
Sure.
Yes. Examining the patient setting, certainly from our perspective, I work on the behavior supports outreach team from the Woodstock Hospital. And so our team, we have patient settings in community, residential, such as retirement homes, the hospital setting, and the long-term care setting. So definitely the ability to do those patient engagement visits in community settings are not happening because of the isolation protocols, and certainly reinforces that isolation, especially in patients and caregivers suffering from mild cognitive impairment or stages of dementia and not understanding what those needs of isolation are. It adds another layer within the pandemic, certainly as to support that need for the patient, and also ensuring if that patient is in the right environment. One can appreciate for sure the movement within long-term care settings is not happening as frequently because the patient moving into long-term care also requires isolation. So even when we're talking about nursing, even paring it down just a little bit further, we have a lot of interaction with personal support workers. So there's been a definite shortage of personal support workers also providing that home care for individuals in the community setting, which in turn puts a resultant demand on hospital beds and bed utilization in hospital. And at times it really creates a discharge dilemma if a patient is unwell or unable to go home. And nurses in the hospital setting for certain really rely on that family or caregiver to come in and attend if it is somebody suffering with stages of dementia requiring that behavioral intervention or that feeding assistance or that bathing or just being that familiar person. So certainly to support that clientele has become a more challenge for our team. The tiny bit of a silver lining that has come out of this that we found, we work very closely with our community partners. And as such, everybody has direct responsibilities with their work. We had previously had a monthly meeting, pre-COVID, had a monthly meeting with limited engagement of our partners because of the responsibilities of their positions. Due to COVID and the restrictions of everyone to do the work and doing it differently, we've shifted and we've got at least 85% participation with our partners on a weekly basis now to help problem solve some of those more direct, challenging cases, and have actually improved linkages with some community partners that didn't previously have a well ingrained relationship, working relationship. And we're working collaboratively with one another and working better for that patient outcome.
Yeah, the thing is, what about, you said because you were not, the nurses were not getting the additional support. So physically, probably the work is draining them. But what about the mental and spiritual aspects of the nurses? Is it being taken care of?
There is absolutely the ability to access the employee assistant program. I know that that's being acknowledged. Staff have the opportunity to reach out as needed. It's available. Our organization developed a wellness room here at Woodstock Hospital for staff to just utilize as needed as well when on shift. And we have certainly a lot of wellness initiatives happening, just even basically within our cafeteria on a Thursday. They're just doing a luncheon where staff can perhaps still distance appropriately, but engage with one another. And everybody's been very isolated, certainly with the physical distancing. And certainly the cafeteria has changed, and the physical work environment space has changed as well.
Okay, so you call this wellness?
It was a wellness initiative. So our organization.
What all are the initiatives that are there in this?
Within the wellness team here, they promote information. So, for example, August is Foot Care Month, so they've showcased in a hallway showcase healthy initiatives for foot care and tidbits, and there's an ability to access through human resources any type of service that's required in terms of each month, Heart Healthy Month, for example. But through our employee assistance program, there is the ability to reach out for any support that's needed.
So it's open to the nurses, and is it only nurses or is it everyone?
It's organizational wide, and they can initiate based on the need. So if it were for mental health services, for example, of course, that would be handled very confidentially, and that access is there for them.
All right. Thank you so much, Karen. Thank you.
Thank you.
Ms. Raya? Ms. Raya is there? Is Raya there? Okay.
No, I think she may be just off camera. She may be back.
Okay. Dr. Selva? Mental, physical, and spiritual well-being of nurses. I think you have already mentioned that all support has been given. Please unmute yourself, Dr. Selva.
Yes, I'm here. Sorry.
Okay. Raya is there. Okay. Okay, you look tired, Raya. You took.
Yeah, no, I'm not tired. It's very hot. It's like almost 39 degrees, but I'm not tired. I'm here, and I'm about the spiritual and the support for nurses. I can say that in our organization, in our hospital, open the internet, and there is an open line for nurses and for any healthcares that challenging some difficult, personal difficulties, family difficulties, or any even mental or spiritual or psychology difficulties, to connect and to get a support by professional team.
So it's a helpline.
Yeah. This is one thing. I know that in other organizations, and also by the Ministry of Health, it's also provided in terms of having an open line for people.
Okay, so it is available for nurses whenever they need it. It's open.
And also nurses and their families.
Families. Oh, that's very good. Thank you, Raya. Thank you. Dr. Selva? You'll have to unmute yourself. Someone has to, Derek, please unmute Dr. Selva.
Yeah, thank you, Dr. Mary. Just a few things that apart from what others have added, as I already said, physically they looked after. One thing I wanted to say is that, first of all, the stress on the nurses who have come without this pandemic training, the country gave a good training for all of them for about 30 hours so that they have that mental stress free to look after these patients.
This was an online training?
Online plus also demonstrated, in terms of how to wear PPE. So that was a big stress that was taken off. Second thing is that the physical help that they offered was all of them are given free food when they came for work. All right. Okay. We may think it's a very simple thing, but it matters a lot, actually.
No, I know, Dr. Titus, because I did my training in St. John's, and one thing good was the nurses were always having free food, but doctors never got.
Yeah,
but
so
I happen to be a favorite of the nurse, so I used to get the free food.
yeah, so that was something that was stressful. That stress was taken off. The other thing is they ensured that whether they are having the PP also in every ICU, there was a room where they could rest. Which was just designated for them with all these gears that they're there. They could rest in case if there is something that they needed a break. Of course, that was something. And then the other thing I wanted to also say, the mental assurance that these nurses had was, most of these nurses, as I said, were expats, and many of them husbands lost their jobs.
Okay.
It's a unit. When you say a nurse, she's a unit of a family. And when a husband has lost a job, she's the only breadwinner. That kind of gave her a psychological well-being, but at the same time a stress because she has to carry double burden of it. And all the children were at home doing homeschooling, So that was a stress. In one way, a satisfaction, they are continuing to work. Secondly, an additional burden of being the breadwinner and not being physically. As I said, they were 2 weeks away in hotels when they were put in here. And that is a bit of a management which the family has to look after. So that has been a stress. But this country as such is a, faith-based community totally. And that kind of gave them, I think most of the nurses, if I haven't done a great researching, but some of them, if you ask, it is their internal conviction and faith that they have helped them move on. As you rightly said earlier, they're not belonging to this country. They belong to somewhere else. And they have this fear of their family at home, especially where if I speak about India and the situation there, that kind of stress has been there. But realizing that they hold a job and they have a support which is going on, that has kept them going. The other thing the country did is they had a national campaign for mental health, multiple ways by which, not only for the nurses, healthcare workers, but for anybody, if you need it, there was counseling that is available as well.
This is for COVID. This is during the COVID time.
It's just COVID time. Multiple national mental health campaign that was there where, hotlines were there. They could call, if they feel that is something that they could not get from their workplace, but they wanted to speak about it, they could do that. That was something that was available to them. So, and then of course, when you talk about PPE not having, that was never there. That was adequate, when looking after. But of course, when they wanted to actually go and be with the patient longer, but they cannot. That is something that nurse desires, when somebody's, and because of the restrictions of going there, doing things and coming, not able to spend enough time with the patient, those sort of things have been a bit of a concern for them. But on the whole, they spend more time than any other healthcare worker with the patient.
Yes.
So
correct.
that is something that I want to say. But of course, they are in another country, that is something that is affected. One more thing I will tell you, what I found out is that many of them said, ma'am, we have not been able to go to, for example, if she's a Christian, I'm not been able to go to church on a Friday because I'm at, work or something. But most of the churches have become online.
Yes, that's
and
a good
that
thing.
has given a great deal of support to the nurses where they could gain spiritual help through these meetings. And I can see umpteen number of them attending multiple kind of worship through this, media, which we never thought we could do. So these are how they have derived their support in terms of faith, in terms of, physical health and so on. Yes, but they still have the huge dilemma, what's going to happen to them? Will their husbands get a job? What will happen to, how are they going to move on? How are they going to support their children's studies? Those sort of mental issues are there. But when you look after, they feel that they are now in a responsible position and they need to do the best that they need to.
Yeah, thank you, Dr. Selva. I understand this because like I said in the previous thing, my mother's a nurse. And she was practically the breadwinner in our house. We have 4 children. And I can understand what stress this will create with the pandemic. Thank you, Dr. Selva. I'll go to Dr. Miriam. Dr. Miriam? Oh dear, have you lost her? Dr. Derek?
I think she's...
Okay, just keep an eye.
I'll put a chat for her.
Yeah. Dr. Joyce, can I come to you? Dr. Joyce? Is Dr. Joyce there? Dr. Joyce Newman? You'll have to unmute Dr. Joyce, I think.
Done.
Yeah.
Hi.
Yeah.
I think this is this is a major issue as far as resiliency. And I just posted a comment that said, that mentions the American Nurses Association coming out with an call to action paper on resiliency. This was pre-COVID, but I think it has a lot of relevance to the discussion and to our current time. So I know we in the institution, as was mentioned already, employee assistance programs are so important for supporting nurses. And I think if we also do ethics rounds with nursing staff, which also helps. And so the call to action paper by the American Nurses Association also mentions several Johns Hopkins programs and other programs around the country which really help to build this. But I think having discussions and having nurses have the opportunity to get support, whether it's chaplain service or whether it's from our colleagues in palliative care as well as other areas, is so important. And so I think, you know, we're doing our best to support nurses. Some call it the reluctant heroes of this pandemic. And, you know, we need to continue to support them as best we can.
Dr. Joyce, do they get any extra pay for this, or do they are they covered by insurance?
They are covered by insurance. I know we also have COVID testing available to employees. There is some institutions have hazard pay.
Yeah.
So those nurses that work on the COVID unit themselves.
They're getting the hazard pay, okay.
Getting a hazard pay.
All
but
right,
that I don't think that's universal, but.
Yeah. Right. Thank you so much. Dr. Miriam, you're back. I can see you.
Yes, thank you. Yeah, thank you very much, Prof. Mary. Yes, talking about psychosocial issues and spiritual issues of nurses, I think here we are doing very well. But there are some lessons to learn though. In the national hospitals, there are wards that have been set aside for healthcare workers who are suspected of having COVID. But when they turn positive, then the hospitals have provision for where to put them in, so they get the care. But the care here may not be as good as the national private hospitals, but it is a good thing that the government has thought about that. The issue of insurance is still a challenge. For the nurses who have been exposed to looking after patients who turn positive, sometimes patients come in and we never know that they are positive until a test is done. So such nurses, there are facilities where they are kept in. I think where we need to pull our socks then is looking after the families of these nurses. I think I have learned this. Yes, I think that
is very important. Yes.
There is the issue of debriefing that is usually done. And then there are so many webinars now that the nurses can join that talk about psychosocial aspects and mental health well-being. We have a call center at the National Nurses Association of Kenya for the nurses, for the medical practitioners, for all other healthcare workers to call in. It's usually 24 hours. It works 24 hours, so they can call in anytime. There was an allowance that was given by the president for all healthcare workers.
I think you mentioned this, the allowance that was given to all healthcare workers, yes.
Yes, was given to all healthcare workers. I think the issue was they argued that they are all on the shop floor, so why should others get more than others? So those are issues that needed to be looked into. Otherwise, I think that's an area that we are doing very well. The issue of moral distress, yes, true. As my colleagues have said, as nurses, when a patient is very sick, you would really want the relatives to be with them, or you would want to be with them for most of the time. But this is a situation where from the time the patient who tests positive for COVID gets into the hospital, they are not able to see their relatives they left behind. And you watch them agonizing, and the situation gets worse. and they die before now they can have that kind of dialogue with their families. So what the hospitals do, there are some phones, telephones that have been given to them, so they can be able to talk to families. But this is in the capital centers. In the rural centers, that is not very well taken care of. Yeah, so I think this is an area we are trying to do well, but we could do more. Thank you very much.
Thank you, Dr. Mariam. Thank you. So I will go to Dr. I hope I haven't left out anyone other than Dr. Annie and Dr. Kristen. We will get the final words from Dr. Annie and then Dr. Kristen. And if we have any questions in the chat box that or a participant who would like to ask a question, we'll take those. So first, let me go to Dr. Annie. You'll have to unmute.
Yeah, here in India, I would like to talk on two aspects. One is private sector and the public sector. And during this COVID season, the pandemic, majority of the cases were handled by only the government hospital and the government nurses. Initially, private hospitals were not willing and coming over, but later on, they started giving their beds, about 10 to 20 beds, whichever.
In Karnataka, they said 50% of the private hospital beds should be given to the...
Oh, here it is 30%. Okay. So not every hospital will volunteer for this. So in that way, even today, the private practitioners who are sitting over here in Tamil Nadu, I'm sure they all immediately send the patient to the government hospital. This is the scenario. In that case, the physical, when I think of my nurses, the physical load, when she has to attend so many cases during the shift. For example, but one thing I have to appreciate here in Tamil Nadu, it is a 8-hour shift. So it is easy for them and to not
because,
like a tedious
12-hour shift. Dr. Annie, there is enough of concerns in the chat box saying 12 hours shift is a bit too much.
But here in Tamil Nadu, it is 8-hour shift. So it is easy for our nurses really to go back, 3 days of work and 7 days off, and 3 days of work and 7 days off. And during they have given during the work time and the 7 days break over time, they have given accommodation either within the hostels or in the hotel rooms the government has provided. I think almost it has been done throughout the country in the same manner. But earlier it was 14 days, 7 days work, 14 days break, and later us keeps changing the protocols. They said 3 days work and 7 days. Now presently 3 days work and 7 days break. And during that time, they are giving free food and, like all this Indian Siddha Ayurvedic medicines like Kabasura, Kudineer and all that they are started giving. They are giving to the nurses also, and also breakfast, lunch. During the shift, it is free of cost. It is being provided for the nurses over there. And one thing here, everybody, whom I interacted with the government nurses, and they were telling they are really not able to touch and do the care. This is what many of the nurses who expressed to me from the government. Because
the human aspect is totally gone out of it.
Gone, yeah. That is what, even with the gears and everything, they really not to hold them.
Yes, because right now we are all recognizing each other through our eyes. Yes, the eyes are our only identifying feature right now.
Yeah, that is the main thing, because the ingredient of nursing is the touch. That is not really been given like inhuman way. They were felt like we are not able to, even when we are talking, it is not loud enough like to reach people. They are already weak, and especially the old age people. They were telling they were really go closer to the face and they need to talk and all that. They were sharing with me, some of the nurses. So that is the one thing physically. And also regarding like in government to take care of them, they have given 1 month extra salary for all the government nurses.
This is only for Tamil Nadu.
It's only for Tamil Nadu. Yeah. Okay. And also regarding...
What about the doctors, Annie?
A doctor's not 1 month salary, I think they did not give.
Okay.
Only for the nurses.
Only nurses. Okay.
Only for the
ones.
nurses.
Okay.
Yes. And regarding the nurses were really prepared from Government of India. I got app. Every Android mobile, they were downloaded and they can see how to don and how to doff and all that self so that was very easy for them because it has been given from Government of India. So uniformly throughout the country, we could follow the same standard of everything like protocol and everything. So that is one thing I want to tell here in the physically when it comes to. And when it comes to private sector, it depends upon the hospital. Maybe Joy Kessia Hospital is really rich enough to provide.
Joy is the mother there. So.
Yeah, it is rich enough to provide, but some of the middle level, medium care hospital may not be, those things are not possible. So that is also there. Then mentally, when it comes to, there is a common hotline provided by the government of Tamil Nadu and by government of India also. All the health workers can call and get a counseling, but there is no separate nurses hotline was not provided for psychological.
Do you think it is? Do you think it is important?
Absolutely, it is important. Even in the council, I collected all the psychiatric nurses numbers and everything. But somewhat ethically, I was thinking, but their personal numbers goes on.
No, but this should come from the nursing council. It shouldn't be a personal.
Yeah, that is why we thought, and we have discussed, and we said let the government has to do, not why from the council and all that. So,
but it can be a recommendation, Dr. Annie.
Yes, definitely. Yeah. So that is definitely we have taken. When this is what they said, it is a common line. Everybody can, all health workers, separate hotline has been given. Yeah. So, but I think it need to be as everybody suggested in every country as a separate hotline. I think I will stress more on this.
I think it's important.
Government. Yeah.
And it's not difficult.
It is not difficult at all. And coming to the social aspect, when it comes to in India, it is entirely a different scenario. And I have to see in a different sector. The nurses the nurses work here and they get recovered, and 7 days they go back home. And when they go back home, some of the public, they were not ready to, they were telling them to vacate the house.
Yeah.
In the rented house.
Same thing, we had the same problems even for the doctors. They were ostracized and the residents were all thrown out of their
and it was quite pathetic in that discrimination was there. And especially, I told the last time we had 4 deaths from Tamil Nadu. Within this week, we had 2 deaths from government. 2 nurses given their life. So, and one nurse who was passed just 2 days before, they were not allowing in the graveyard to bury.
Yes,
yeah, that was a big issue we faced, and all. That's a thing which puts every nurse into though I'm doing so much, you can see the social media, all those reacting. But when it's for a doctor, it has been big media boom. But when it's for nurse, it has not been allowed to bury. It is not at all a news.
Dr. Annie, it is not only for nurse, it is for all healthcare workers. People are very worried. They don't even, for me, my maid refuses to come to my house now.
Okay. So, no, here, why I'm telling is when first time one doctor passed away, it was a big boom in the media.
Yes.
They were all talking about it. But this nurse, when she passed away 2 days back, it was all so much in the media.
That is what was put in the chat box. When a doctor dies, it becomes the politician talks about it. But when a nurse, something happens. Dies.
Yeah, definitely. That discrimination is there. But though there is a little bit of a thin gray line, I could see here is our PM, our Prime Minister of India. He spoke to one of the nurse who was taking care of a patient with COVID-19. The first time a Prime Minister talking to a nurse on the hotline, and he spoke to the association leaders. And it was a good recognition we felt as a nursing fraternity. And the second thing in this, I think this last week, Rakhi, that festival came, first time the nurses president called the nurses from private sector and the government sector from army. They went and tied a Rakhi for president. These are all the recognition first time we are getting.
It's just the fact that you're recognized, if not,
this is something very, very, appreciating as a socially to think of, or, to boost up our morale as a nurse.
Dr. Annie, I want to tell you, we've had this 2 weeks of this, two sessions of discussion. Has it been informative? Are you going to take back anything positive out of this and suggestions? I want to know, because we've been talking so much.
Actually, I'm working onto it as usual, Dr. Mary. Last time when we did the bioethics one, I just gave, I hope you all remember the curriculum framed, and I gave a concept note to you. I hope I sent it to Dr. Russell and everybody. And the same way I'm preparing onto this based on everybody's experience. Actually, I'm just using the recording which Dr. Derek has sent. And
No,
everyone, I'm putting their name and writing.
No,
the
it's not that. It's not that, Dr. Annie. Something good should happen out of this. Something
Yeah, that is
positive
what-
should come out of this. We have to move forward because we
Yeah.
can have 100 webinars and nothing can happen.
That's
But we
true.
should use this as a stepping stone to do something more.
It gives me a lot of confidence when there are so many nurses with me globally facing the same challenges they could achieve. Definitely we as Indians, we could achieve. And finally, the spiritual aspect everybody was talking about here. In India, unfortunately, I think Dr. Mary also will accept with me, in most of the government hospital, we don't really have such pastoral care or a chaplaincy care. We don't have such things. But in a private sector, definitely there is, like I'm from CMC, Velo, and there's a separate chaplaincy department and there is a pastoral care being given. And depending upon the hospital, the mission hospital, they might be providing. I don't know about others, how they are, but my basics I have done from government college, but there I have not seen any spiritual care. Till date, I don't think people have taken seriously about this spiritual thing.
Do you think do you think it is a suggestion that you can put forward?
It is a suggestion. Definitely, I'm going to put this. This is a suggestion. One thing I have taken from this forum, one thing is spiritual, how, and the Directorate of Nursing I need to take forward, and the hotline for nurses separately, like other nurses. And some of them have said that there is a risk allowance, hazard allowance, right?
Hazard allowance.
Yeah, those things, it is in my mind that I need to write to the government.
No, because the
Odisha
government, the minister has already, chief minister has already said that all healthcare workers will get an allowance, and they've given the amount also.
Oh, that's great. Okay. Yeah. So here, so far, nothing like that, any risk allowance, nothing is not there. So this is how I think I look at, on a whole, like in a different aspect. And one more thing I never want to forget is public health side. See, ANMs, auxiliary nurse midwives, that is village health nurse, is our boon for our system of India. They are the one going each and every house and doing the screening and doing everything. And we shouldn't forget those people,
because they should be included in the allowance, in the voice, everything.
Yeah, that is what, because people all are talking about the hospital clinical nurse. They are really not talking about the public health sector. I think we need to focus on them, and their work cannot be forgotten. Really, they need, because their stress is something different. They have to go and visit each family.
No, and why they face a lot of violence also, because
yes, definitely, yes, they do face it, and we have seen here and there in the media reporting about that. So the great work, and especially from village health, village health nurse, they have to do the antenatal follow-up and everything, and they come to the primary health center for delivery, and there whether adequately PPE and everything being stored, and sometimes the ANM, the staff nurse who's working in the primary health center, whether she's ready to conduct the delivery. Most of the time, what I heard was people, they immediately refer any simple thing, they refer to the tertiary hospital. So those transporting time, these are all the big ethical guilt which should go in their mind. Going in their mind, whether am I doing right thing, because they are very scared to do all these things. So I think in that way, that moral responsibility, the moral resilience has been really taken part so much in every nurse's life, whether it is a public health or a clinical nurse.
Yeah, the thing is, there are so many problems. We can go on, we can have 100 webinars on this issue, but just bringing out these points itself is a big thing, and we have to move forward and we have to do something positive about this. We can talk our hearts out, but if we don't do anything, then this is all be, of waste and useless. Yeah. So thank you, Dr. Annie. And last person I'd go to is Kristen. Yeah, Kristen. Kristen, you're self-muting.
Great, thank you. So thank you, Dr. Mary, and thank you to everyone, all the panelists, and all of the wonderful questions from the audience. I appreciate the opportunity to close off this webinar with just a few thoughts. Throughout this discussion, I was thinking about the Chinese symbol for crisis, and that symbol actually indicates both danger and opportunity. So I feel like we've had the chance today to not only discuss mitigating danger, but what are the opportunities for nurses moving forward. And this has been an excellent venue for the voice of nurses globally, to not only be reactive, but responsive, and to think about how we can do things better in the future, not only in curricula, but also in clinical practice. And I think, you know, one of the opportunities that we have here is to address things like burnout, compassion fatigue, moral distress, moral injury, physical and emotional exhaustion of nurses. These are not new issues, but hopefully COVID has allowed a light to be shone on some of these areas. Not only do we need to focus on hotlines and opportunities for people to reach out to a chaplain, let's talk about prevention. Let's talk about health promotion of nurses. Early intervention.
Even Kristen, sorry, but I also like this thing about telehealth. I think we should take telehealth in a, use it to our advantage in pandemics.
I agree. There's a lot of opportunities now with technology that we can reach out to nurses and we can reach out to each other. And just in the context of this webinar opportunity for nurses, I think there's inherent value just in coming together and the solidarity of hearing the fact that we're all in this together. We're all experiencing the same things. And one of the key strengths for nurses is our ability to give compassion to patients, families, and communities. I think it's also time for us to give compassion to ourselves as nurses and as healthcare providers.
I think we have to be kind to ourselves. That is very
important. So thank you for this opportunity to validate global experiences. Thank you, Dr.
Thank
Murray.
you, Kristen, for co-hosting this. And I think it's a beautiful platform. And this is, of all the webinars that I've moderated, this is the one that is most, closest to my heart, and you know why also. So, Dr. Derek, do we have any questions, or is there anything we would like to take from? I know all of you are looking into the chat box, and if you'd like to answer some of their questions, this is to the panelists, you can do so.
Yeah, I think most of the questions, Dr. Mary, were answered on the spot or during the discussions that took place. So to whatever that I could notice, there was not really any issue that was left out of the discussion. Of course, the suggestions are always there. The problems have come to the forefront. And it's very heartening to see that the broader issues remain the same. And of course, one thing, even though I'm not really sure whether UNESCO can take a lead in, addressing your individual problems at the state level, what we can do is, at least to the panelists who are here, we can share the list of the people who are registered, who themselves would comprise a large percentage of nursing faculty, nursing students. So that can be the start of a core group. And I'm sure if each one of us have the solidarity to connect together, to come up with a white paper of the problems and issues that are common worldwide. So we have people, and I'm glad to hear from Judy and Selva and Annabelle and all the people in your respective countries that you already have some access. And if we can put this formally together with signatures, with emails from the participants, which I will give you access to, I think that will give you the strength of numbers.
Provided
so everything works.
Derek, provided the participants have no objection to this?
Since they have registered, we can send them individual emails asking if they would like to be part of the project. So we can continue this offline. And in terms of this, I think the UNESCO team can take a lead in this of preparing a white paper. And we can even circulate a Google form asking, would you like to be part of the project? We can get their further details in terms of their positions, in terms of their access that they can have. So it can be a starting platform, step by step. And we can take the lead, and definitely there are a lot of issues that have to be addressed. We are aware of it. And every webinar that we've had so far has brought out the problems to the fore, and we can start thinking of solutions so that in future we are better prepared. And like I always say, these are the positives that have come out from the pandemic. Let us seize the opportunity. And I'm sure that as things improve and the focus shifts away from active healthcare and looking at active cases. And in the follow-up days, definitely the voice of healthcare will be heard much more, because we've been talking about this for so many years, whether it's doctors or the entire healthcare profession. But governments and administrators have just thought that you are pressing the panic button too early. And now, of course, worldwide, the situation has proved different. So when we talk about planning for the future, then I think our voices will be heard. So this is a good time to prepare. While we are actively treating cases, let us think of the future. Let us plan for the future. And I think that will be a good place to start. One personal opinion that I had regarding changes in the curriculum and the pandemic, just let me play devil's advocate for a minute. Unfortunately, what happens is with every new disease that comes up or new bit of information that comes, we want to keep adding it in the curriculum. And we end up actually burdening our students, I feel, because we can't expect them to learn everything about everything. And that's a tragedy which happens. You give a curriculum to a particular department and they expect the students to know everything about everything, literally. I've gone through it myself. So if we go and study the core issues regarding the pandemic, it was more of back to basics. And rest we have learned on the job. As we got new information about this virus, about its behavior, you go through the literature and you see sometimes the treatment protocols, the understanding have turned 180 degrees. So it becomes quite difficult. Let's not jump the gun and maybe try to put everything into like a curriculum. But more important, I feel, is to stress upon the basics, to stress upon how to address a disaster when it comes, so that mentally we are stronger rather than focus on, today everything is about COVID-19. It's as if we've suddenly become disease free and the only disease we need to bother about is COVID. So let's not forget the other diseases are still there. There are other diseases with higher mortality rates. There are other diseases which are still pandemic in larger parts of the world, as Miriam will bring out. There are other issues which are still there as part of public health nursing, very, very basic issues of nutrition, childcare, which need to be addressed. So let's not focus too much on COVID. Yes, it is a high impact right now, but tomorrow we'll have to get back to normal life, and let's keep that in mind. So that was just something that I wanted to
Dr. Derek,
share.
I just want to add on that, because there was a paper which was published by Dr. Madhukar Pai, and he talked about something called COVIDization of research. And he was talking about millions of dollars are being now spent for the pandemic. In fact, if you were to write for a grant right now, you will not get a grant for all the other non-communicable disease other than COVID-19. And he said the worst thing that has happened is about, changing today. One paper says hydroxychloroquine is good. The next day it says it's bad, and it becomes so much money is wasted. And he cites an example about the Ebola virus and the Zika virus that had happened. And it came as like a, epidemic, and suddenly it disappeared. So whatever was done in that effort just ceased. But what happened that was in 2016. But what happened in 2018 when Ebola came back to Congo, whatever was done in 2016 just disappeared. So they had to restart again. So when we talk about including it into the curriculum, it's not that that others are not important, but this aspect also is important, because we are not, probably this may not be the only pandemic we're going to see. So burdening the students, yes, but at least some sort of, because I think one of our panelists said, I think it's Rebelli who said that when they go for re-registration, they need to know about COVID-19. So something like that is also a very good suggestion. So that, I'm just informing you about, when it comes to curriculum. Thank you. Dr. Russell, would you like to close?
Yes. Yeah, thank you, Dr. Mary and Dr. Derek and Kristen, Annie. I think this was a great session where many things have come forward. But to add to all what you said, I think we had one webinar where we were talking, and there was a chap, Professor Amit Banerjee, is that right? And he brought this issue that so much is happening with COVID that he showed a drop in the picking up of tuberculosis, which
yes, tuberculosis.
because of this, yes. And he said tuberculosis had a 20% mortality with treatment. With treatment, right? With treatment, it had a 20%, and suddenly that had gone because all the resources were here, and these people are, and that's a good thing to remember. We are focused on this, but certainly, and we can see, well, in Australia and the rest of the world, people with cancer are not having there's not enough attention. They are neither themselves, they're scared to go in, and this has been an important issue that we learned. But I think overall, this is a great, it was a great opportunity. And what I've already told all of you, this panel, including the others who couldn't be here, we're going to get this, like we did, a very similar issue came up with the pharmacy. And first time they had an opportunity to come across from the rest of the world, and they realized, and so we have this a deeper conversation going where they've already written out a couple of things that they're looking at, and if nothing, it's coming up with from the ethical aspects dealing with a pandemic. And here's a pan global team of nurses, professional nurses from, and on the platform of the UNESCO Chair in Bioethics, we are forming an opportunity to put some thoughts together from taking this further and coming out with one will be doing the proceedings, as I've said. Professor Kahal will give a summary as he did of last week too, but we're going to put this, and so the proceedings will be published. That can be quoted then after you put this together, and then the guidelines for some of the things that we've spoken about, in particular, the ethical issues that have emerged from this pandemic. As we all said, none of us here have had the experience of working or living with a pandemic ever before. And, we've had epidemics and so forth, but not a pandemic, a global, like what we're having. This is once in a lifetime. Well, it's about 100 years. And we hope it'll be another 100 years before a next one comes. But whatever it is, this is a good opportunity for all of you. And then the others, the other participants will also have access to refer to this two important webinars. And down the track, as we go through, you might like to reconvene, and that's what the group will decide. So I'm going to send this out to all of you, and we'll get you to take this forward. I think someone's sharing their screen with us. Yeah. Anyhow, so I want to put that forward to all of you, and thank you all for giving your contributing with your precious time, your knowledge, your knowledge coming from a lot of years of experience and so forth. So we are very the UNESCO Chair in Bioethics my team and indeed the Department of Education that I head is very, very appreciative of your contribution to the greater good, but very importantly, the displaying of solidarity across the world as we are in this together, and will come out of this hopefully very positively together. So with that, we'll continue to be in touch and in taking this forward, and hopefully you might reconvene down the track again. Okay.
Thank you.
Thank you all. Thank you, Dr. Mary and Derek.
Thank you, everyone.
All the help. And Annie.
Thank you all, everybody.
Wonderful session. Wonderful
Yes,
session.
wonderful
Thank you.
session.
Thank you, each
Dr.
and
Mary,
everyone.
special thank you for such a wonderful moderation. Thank you.
Thank you, Dr. Annie.
All right.
Yeah,
So stay well, stay safe, stay well, all of you.
And thank you all the participants as well. Your
Yes,
inputs and your
answering all the questions.
helping out was really good. I think
Yeah.
it was really helpful. We got so many opinions from all over the world. So that's wonderful. We were all co-learners, as Dr. Russell keeps reminding us. And I think we've all got enriched from this. Thank you, the panelists. Thank you, the participants. And thank you, Dr. Russell, Dr. Mary. Excellent, as always.
On behalf of all
Very
panelists, I thank Dr. Russell and his team once again for giving such an opportunity to
Thank you,
convene
Dr.
this
Annie.
program, to bring such a wonderful ideas from other countries. And as Dr. Derek says, and we need to put together and take a lead. Thank you for such a wonderful suggestion, Dr. Derek. It is really an awesome idea. I never thought about it. You can take a lead through UNESCO. I think I will be catching up with Dr. Russell and your team, not leaving you all. Thank you
Annie,
so
we've
much.
passed the torch on. You need to carry it on.
Yes, sure, definitely.
We'll see whether you say thank you after 6 months or not.
Yeah, we will.
You'll say, what did you pass on to me? No, but let's take it seriously. As Dr. Mary said, we need to have an outcome that is more important. You know, it always feels good when we finish such an exercise, but until it is carried forward to its conclusion, maybe a year down the line, we'll see some serious improvement all across the world, and that will be a time to congratulate each other. So let's aim for that, and we have Dr. Russell with us, so I'm sure it'll be a reality soon. It will be a reality soon.
Thank you.
Sure.
Thank you, everyone.
Thank you, Dr. Miriam, for
have a nice day. Have a nice evening, each and every one of you. And thank you, Dr. Miriam.
Yes,
always good to have you.
Bye-bye.
Bye-bye.
Bye-bye. Stay well.
Thank you, Joe.